quickly within 5-10 seconds they join all the students, then we can go for the live.
Done, sir.
Yeah, thank you. So good evening and welcome all of you for the NOEL sessions today's session. So this year's it is the 4th year consecutive year of NOEL session and 4th year to the 8th session. In the first 7 session, as all of you are aware, all the students trainees, we covered the respiratory care, including ventilation, resuscitation, and the last session was on HFO. So after completing the respiratory care, we are now moving today onwards. It's a neurology bundle, neurology module, which will be around 6 sessions of neurology and different cases and topics we'll discuss. To begin the neurology module, today we have planned to discuss about a bedside case presentation of a very common disease in newborn. That's a neonatal seizure. The disease is common, but sometimes it poses challenge in the evaluation and managing the difficult refractory seizure cases. To learn how to evaluate, how to go to the differential diagnosis of neonatal seizure, and then the challenging cases, how to manage it well. These 2 points probably we'll learn through the session of presentation. So to presentation to start, Dr. Sirisa is neonatology fellow. She joined just shortly within last month only. She joined as a fellow trainee with us in Rainbow Children Hospital, Hyderabad. She is going to present the case, which is a case shortly 1 month before admitted to our hospital, and detail with including the diagnosis. And as a faculty, today 2 of the eminent faculty joined with us to carry the discussion further. To introduce you, Dr. Uma Maheshwari. So she does not require any introduction. She is quite active in the neonatal academic field across the country. She is now neonatology head of department of SRMC Medical College. So all the students and the trainees, including DM, DNB neonatology, they know Madam actually very well. So to lead this, I invite her to initiate the discussion any point of time. She can, please stop the student. You can discuss, ma'am, any of the aspects of clinical aspects. And end of the session, we will take the question from students and we will follow the, will try to answer all the faculties. So here the session will be moderated by our Rainbow faculty, Dr. Vamsi Krishna. See, he is a DM neonatology, joined with us last 1 year. He is as a consultant. He will moderate the session, help the student, and during clarification of the case whenever required. And from the case is a neonatal seizure case with little difficult, challenging diagnosis. We have invited today pediatric neurologist, our faculty, Dr. Nikit Shah, who is a pediatric neurologist with special interest in neonatal seizure. Because our pediatric neurology department, they decided degenerative disease, myopathy, the disease was neonatal seizure. They have special interest. Dr. Nikit, special interest in neonatal seizure evaluation and treatment. So both the faculties plus the moderator will lead the session. Before inviting Dr. Sirisa, I will request both the faculties, what's your expectation from the session? You can put 1 or 2 words to the student delegates so that they will follow and they will ask us the questions. And the student presenter, Dr. Sirisa. Madam, starting from you, you can introduce a little bit whatever your expectation, then we'll go for the presentation directly.
Good afternoon, good evening, everyone. And I would like to thank Dr. Nalinikant for inviting me over for this session. Always IEM is close to my heart, inborn errors of metabolism. Especially I'm looking for like something treatable. I think maybe the presenter might be kind of bringing out like different perspective of neonatal seizures. So my expectation is a systematic approach and how the case was evaluated. So that was my expectation out of this. I'm looking forward for a good discussion along with my neurologist who is there as a colleague of me sharing the platform today. Thank you.
Yeah.
So perfect. Nikit.
Yeah, thank you. I think as Madam said, systematic approach is more important. There are few patients who will come with a diagnosis. I mean, something like HI, hypoglycemia, but sometimes they still pose as a challenge. When there is no clear-cut diagnosis based on history, I think it is important that we look for treatable causes and then evaluate for non-treatable causes as the time goes. And we'll discuss how the things, what should be the flow of investigation, what should be the flow of history, and how do we approach a patient with neonatal seizures based on the clinical presentation. What clues you need to look for? What are the treatable IMs? What are what are the clues on examination? What we can pick up for more narrowing down the investigations, because we cannot order a battery of investigations in many patients because of pay for service kind of thing in our country. We may be restricted sometimes monetarily, and in that situation we have to channelize the investigations. We cannot order all of them, but what basic investigations to order, how to go further, and how to make utilization of genetics is, I think I'm looking forward for those points to discuss during the case.
So perfectly fine with the introduction to the expectation of the session. I will just invite Dr. Sirisa, please share your PPT and try to be more methodically in your approach. All we are listening. In the meantime, any point of time, any interaction, you want to ask few of the questions during presentation, one or two, you can ask so that the delegates, the student trainees, they will answer, and later we can answer with the faculty's inputs also. Thank you. Dr. Sirisa, with all the best wishes, you can go ahead with the presentation.
Thank you, sir. I'll share the screen. I'll start this.
Yeah, hi Sirisha. Please start the presentation.
Okay, sir. Good evening, everyone. Today I'll be presenting case details of a baby who presented with seizures. Coming into case details, it was a 16-day-old baby of M who presented to our hospital with chief complaints of jerky movements of upper limbs initially and then followed by lower limbs, and also decreased activity after that episode for past 2 days. Coming to how it started, mother described it as the movements started first in the upper limbs and then followed by lower limbs. There were 2 such episodes in the past 2 days, which lasted for 2 minutes. Along with these jerky movements, she also observed that there was horizontal jerky movement in the eyes too. So when we asked whether it was the first episode, she told this started on day 7 of life. Baby had these seizures in the form of jerky movements of the both upper limbs and lower limbs on day 7 of life. Then it was for 1 minute. During that episode, there was no associated fever. She was treated elsewhere with loading dose of antiepileptic, that is levetiracetam. And following day, there were no seizures and discharge on oral levetiracetam. Mother also observed for the past 15 days after birth, she also observed there was increased floppiness and easy slippage of the baby through hands. So during these movements, as I said, there was no history of fever, and these movements were never observed during sleep, and they were not settling or coming down with touch, and they are not stimulus sensitive, and there was no history of vomiting. So coming to antenatal history, it was gravida 2 para 1. First one was spontaneous miscarriage at 7 weeks of gestation.
Sirisha, may I interrupt you,
Sure,
at this point of time? So any specific reasons why you were asking for fever history? Because 2 times you mentioned about fever.
Ma'am, to rule out infectious causes of fever, infectious causes of seizures, ma'am.
Okay, so what is more common as an infection manifestation in newborn, especially like pediatric?
Meningitis and encephalitis may present with fever and seizures with decreased activity. So I asked for fever.
Which is more of temperature instability rather than fever. It can be either hypothermia or hyperthermia.
Yes, ma'am.
And also any other important specifications when you are mentioning about movement? You said it is not stimulus sensitive. Yes, you did try to differentiate between other etiologies. Any other specific thing which you would be specifically asking for the mother?
I want to differentiate it from jitteriness. So I asked whether it was.
That is right. Anything else will help you to differentiate. Did you ask like what was the eye movement, whether the baby was what is the active state of the baby, whether the baby was active, sleep,
Ma'am,
which
yes, ma'am, I have asked for it. There was decreased activity after that episode, but there was no horizontal deviation of eyes, or there was no flickering of eyes, anything not associated with that. But she observed that there was jerky movement of eyes even during the episode, and after that also that movement was persisting from birth.
so abnormal eye movements were also
Abnormal
associated.
eye movements were associated.
Okay, sure. Go on, carry on.
Okay, ma'am. So antenatal history wise, it's I told there was spontaneous miscarriage and she had regular antenatal checkups. Mother was known to have Graves' disease, for which she was on propyl thiouracil for 14 weeks, later changed to carbimazole. Mother never had fever associated with rash, and she appreciated quickening at 5th month. She was also gestational diabetic and on oral hypoglycemics from second trimester. She received 2 doses of TT injection and there was no increased or decreased amniotic fluid and there was no history of bleeding or leaking PV. But antenatal scans showed in the baby that there was ventriculomegaly and echogenic kidneys in the 7th month of gestation. Coming to birth
Sorry,
history.
go back.
Yes, ma'am.
So propyl thiouracil and carbimazole. So what is your take on teratogenicity?
Yes, it will have effects on embryopathy, and in the first trimester, there will be formation of fetus. So it might interfere with that. So we avoid methimazole and carbimazole in the first trimester.
Okay. So any specific abnormality you will look for if they are on carbimazole or methimazole in the newborn period? Are you aware of any specific teratogenic effect? Okay, this is there, then it is you will be going back and asking the mother about the medication, anti-thyroid medication.
Specific
Aplasia cutis, yes. Someone has answered, yes, cutis aplasia, yes. Okay, so you said TT injection was given. What is your take on maternal vaccination? Adequate TT injection, what is recommended?
It should be minimal of 2 doses separated by 8 weeks, ma'am. Separated
Are you happy with TT injection or do you want to do something more than that?
TD is advisable nowadays than the TT injection.
Okay. DT? DT is advisable. Is there a pertussis search? Will you advise TDAP? You advise TDAP in the mother?
No, ma'am. TD is advisable.
Pertussis is not a worry for you in the newborn period. Is a herd immunity coming down? You might have to vaccinate the mother. What is cocooning? Have you heard about cocooning? Okay. So pertussis, if you are vaccinating with the pertussis, also the mother, it will be helpful in the neonatal period not to have pertussis. So the recommended vaccination is TDAP, no longer TT as such. So, but it can be given little later than what TT injections are given. And also cocooning is an effect where the baby is protected because all others are vaccinated or they are protected against pertussis. So basically it is a sort of herd immunity where the baby is in the center of the cocoon and the baby is being protected because all others have pertussis vaccination. Done. Okay.
Yes.
So you said antenatal ventriculomegaly. So how do you diagnose ventriculomegaly? What millimeter of ventricles would you take it significant? So do you classify as mild, moderate, severe antenatal ventriculomegaly? So it is whenever it is more than 10 millimeters, then you will be telling as ventriculomegaly. So you classify as mild, moderate, severe. based on 10 to 12, 12 to 15, or more than 15. So with similarly, like mild is mild, isolated, or unilateral has a better prognosis, whereas moderate, the prognosis worsens. And if it is a severe ventriculomegaly or it is a progressive ventriculomegaly, the prognosis is worse. And name some etiology for antenatal ventriculomegaly. Can you name some cause? Or a mother is coming to you for counseling. So what are the things which you will be? Someone has put us in intrauterine infection, yes? Something happened? Risha? Okay, so let me enumerate till she gets back. So basically ventriculomegaly can be either problem with the ventricular system, or it can be problem because the cortical matter is less. So the brain atrophy can also lead to ventriculomegaly, or it can be either problem with the system of ventricular drainage. Both can lead on to antenatal ventriculomegaly as such. Sirisha, are you there?
So I'm just trying to reach her actually, but something, we lost her, the connection lost.
Yeah, sure. So basically, like we have to look for other abnormality in terms of whenever there is an antenatal ventriculomegaly. So by 28 weeks scan, we can look for neuronal migration also, kind of listen carefully, all the other things that can be looked at as an associated feature. But at 20 weeks scan, it is very difficult for us to differentiate because we will not expect anything at that stage because the brain will be smooth. For all the fetus, the brain will be smooth at 20 weeks. Only by 28 weeks, you expect sulci and gyri formation. At that time, sulci and gyri formation will not be there. So you need to know the development of CNS as such. What happens first? What is proliferation? What is neuronal migration? What is myelination? And what are the stages in which these occurs? And what are the corresponding congenital malformations which translate to that?
Yeah, I think progressive is more important because if we diagnose some or mild ventriculomegaly at 20 weeks, I think we can't just advise that something is wrong and you discontinue the pregnancy. I think it is important that we follow because it can be just variation if it's not increasing, especially unilateral. I think it can be safely ignored if it's not increasing in size on progressive scans. But if it is worsening, then I think definitely evaluate it. The earliest when we expect some primary fissures to be formed is 24-25 weeks of gestation, I think, on MRI. It may be slightly difficult on ultrasound, but yeah, I think those are the caveats, some caveats here. There are certain things, even if we diagnose early, we cannot definitely give the answers. We have to tell them that we have to follow.
Very true. Yeah, isolated has a good prognosis. But how to determine that it is isolated is a challenge.
Yes. I think size definitely is very important to follow because it's such a small structure, 1 millimeter here and there, and it can actually change from mild to moderate and all those things. So you need a very experienced fetal medicine radiologist, especially when we are in doubt. I think it is always better to take expert advice.
Also, the presence of any other anomalies will increase the risk of the abnormalities for the associated ventricle.
Yeah, I mean, in slightly advanced gestation, those things can be picked up. In early gestation, like between 20 to 24 weeks is always a caveat.
Yeah.
So, yeah.
Dr. Sirisha, are you back?
She has lost the connection.
Yes, ma'am. Yes, ma'am.
Yeah, you can
You
start
share your
sharing the screen
presentation.
and start presenting.
Okay, ma'am.
Maybe we'll let you present the entire history and then ask you again.
My screen is visible, ma'am.
No, your screen we are
Not
not able to see.
yet.
Okay.
So 1 second.
So before coming to this, Sirisa joined here. I said, is it visible? Others can see, ma? Or Dr. Nikit?
Yes, we can
Sister.
see. We can see.
So I shared a document. Just that's the Volpage standard table. I said what are the components to look for. But if Sirisa comes back with the presentation, we can go for presentation later. We can that part we can discuss it.
Please come to
Sirisa, you can go
slide.
presentation. Is there any issue? You can start presenting. Then in the meantime, the faculty can ask you question, but you can start presenting now.
Okay, sir. So coming to birth history, I told it's a born to non-consanguineous parentage delivered at term, and it was through LSCS due to non-progression of labor, and birth weight was 2.75 kg, appropriate for gestational age, said to have cried immediately after birth, but there were no recorded Apgar scores. But history-wise, there was no suggestive perinatal asphyxia history. Baby was started on EBM and discharged home on day 3. In family history, this was born out of non-consanguineous parentage, no history of any hereditary diseases running in family. Socioeconomic history, they belong to upper middle class. Clinical examination wise, baby was drowsy but arousable on pain stimulus. Baby was lying down on couch with upper limbs in flexion and lower limbs in extended posture, but there were occasional active movements of limbs. See, in this picture, baby is lying down with both lower limbs in floppy, as you can see floppiness in that picture. When coming to head to toe examination, there were triangular faces with broad forehead, and anterior fontanelle was flat and wide. There was high arch palate, and there was no molding and no bruises or injuries over scalp. In eyes, nystagmus was seen, cornea was clear, and no cataract was present. In this picture, there was low set ears clearly visible. Next slide, please. See, in this picture, there was low set ears appreciated. Next slide. Nose was normal. In neck, no visible swellings or webbing of neck was seen. Chest was in normal shape and symmetry. Abdomen was not distended, and umbilicus is normal with no redness. External genitalia, bilateral undescended testis was present. Spine was normal, and there was no dimple or tuft of hair. Hips were normal, no dislocation or deformity. In feet, there was bilateral CTED. Skin-wise, there was no abnormality and no neurocutaneous markers or seen. Baby's weight was 2.8 kg, length was 50 centimeters, head circumference was 35 centimeters. All were below the at the 50th centile. Vitals were normal with respiratory rate of 30 per minute, heart rate of 144 per minute, and temperature was normal. Coming to systemic examination, baby is drowsy, arousable on pain stimulus. Weak cry was seen, As I said, baby was moderate stuporous. Cranial nerve examination was normal and there were no tongue fasciculations. Scarp sign was in midline. Popliteal angle was 140 to 160. Heel to ear test, when done, it was just crossing the nipple. Tone, passive tone, excessive floppiness was present. Both axial and appendicular hypotonia was observed. In primitive reflexes, Morose reflex was incomplete. Palmar and plantar grasp was weak. There was no rooting reflex. Sucking reflex was also very weak. Deep tendon reflexes, knee jerk was present. Other system examination, respiratory system wise, there was no tachypnea or respiratory distress, and bilateral air entry was there with clear vesicular breath sounds. Cardiovascular wise, S1 and S2 appreciated and regular rhythm with no murmur. Abdomen as normal shape and no visible distension. And there was no organomegaly. Course in NICU, baby was admitted in NICU for these seizures, started on low flow. Baby had 3 episodes of similar seizures after admission, which was brief for 30 to 40 seconds and multifocal in the form of clonic seizures. Treated with levetiracetam, later phenytoin was also added. As there were multiple episodes of seizures not settling, pyridoxine was also added. Neurologist opinion was sought and planned to start even lacosamide. Over the next 3 days, there were no further seizures. Baby remained encephalopathic when hypotonia persisted. Baby was started on OG feeds, which was gradually increased. The minimal oxygen support was gradually weaned off. The summary, here we are dealing with a term neonate, which was born of non-consanguineous parentage with onset of seizures in first week of life, which were multifocal and clonic in nature, and baby had axial and appendicular more of central hypotonia with dysmorphism, but no probable acute etiology which is leading to this. So coming to etiology of neonatal seizures, major of seizures 30 to 45% will be of hypoxic ischemic encephalopathy. Others will be infectious causes, metabolic, vascular causes, genetic, and brain malformations. And last one will be unknown causes. So with this history and keeping in mind of probable etiologies, we proceeded to work up. So according to time of onset of seizures also, within first 3 days and after 3 days, how the onset of seizures will be is clearly given in this tabular form. First 3 days, if we see, it will be more of hypoxic ischemic encephalopathy, and then followed by intracranial hemorrhage, any intracranial infections or developmental defects, and metabolic disorders like hypoglycemia and hypocalcemia, other epilepsy syndromes. So keeping in mind, we have done workup according to this. Initial investigations. Next slide, please. Complete blood picture showed no abnormality. All the counts were within normal limits. And to rule out hypoglycemia, blood sugars were monitored throughout, but it remained within normal limits. Electrolytes, sodium, calcium, magnesium, all were within normal limits. Renal function test was also in the normal limit. In the ABG, there was no acidosis. pH remained in the normal range. Bicarbonate was also normal. So to rule out we did the investigation initially to rule out metabolic part, that is hypoglycemia, hypocalcemia, hypomagnesemia, all were normal and there was no acidosis also. So to rule out infectious part, CSF analysis was done, but in that CSF glucose protein were in the normal range, and CSF gram stain also showed no cells or organism, and CSF PCR was also negative. So in the blood septic screen, CRP was also in the normal limit, and blood and CSF cultures were sterile. Another common cause which might be leading is intrauterine infection. So to rule out, the torch was done, which was also negative. As the baby has hypotonia, we did thyroid function test and CPK, which was also in the normal range. Echo screening was done. There were no features of failure and it was normal. Liver function test to see any involvement of the liver to rule out inborn errors of metabolism, but liver function was normal. So neuroimaging was done.
Shirisha, can I stop you here?
Yes,
Is
sir.
that okay? Yeah. So with given set of investigation, I think these are all basic investigations which are available as quick as possible bedside. All right.
Yes, sir.
So with the given investigations, what is your thought process here? So baby presents with seizure. On examination, there is hypotonia and some dysmorphic features with normocephaly, and you have some investigations available bedside. So what do you think you should do next, and what causes do you rule out at this point with available investigations?
Sir, as the baby has dysmorphic features with hypotonia and all other routine investigations ruled out metabolic causes of seizures like hypoglycemia, calcemia, and hypomagnesemia, I would like to see any abnormal brain malformations and other inborn errors of metabolism at this point to rule out for causes.
Okay. Now, what are the important clinical clues for brain malformations? Usually, it may not
Head-
be true always, but in majority of the cases.
Head size will be abnormal, sir.
Head size. Yes. So your head size here was normal. So
Yes, sir.
normocephaly is an important finding in your patient summary, right?
Yes.
So I don't think so. You should come up with operant etiological differential as structural malformation.
Yes, sir.
Okay. Yeah, I think that is what I want to say. I mean, MRI, everybody would do MRI, but I think, see, even before ordering the investigation, it is always good to have a thought process. So what
Yes.
other, so you said some common metabolic disorders you ruled out, hypocalcemia, hypoglycemia, and blah, blah things. Again, they are very unlikely or unusual to have on day 7, day 8, or in the first week of, I mean, after first week or in second week of illness. Not that it cannot happen, but very unusual, I would say, especially when baby is tolerating feeding and all those things. So what are other groups of disorders which you have ruled out by available investigations here? Can you rule out organic?
Yes, sir.
So
As there was no acidosis, organic acidemias was also ruled out here, sir.
Okay. What else? By looking at ABG?
In this case, sir?
Yeah, I mean, in general, in a case, in a neonate who presents with seizure.
Yes, sir. In that, we should look for any lactate buildup, lactic acidosis. We should.
Right. Then?
Pyruvate we should look for, sir.
Pyruvate is not available in ABGs, right?
Yes, sir. Lactate is there, sir. Metabolic acidosis basics.
Yes. I think somebody has mentioned ammonia and all. So metabolic alkalosis is also important. It's not just always acidosis that we need to look at.
Yes, sir.
Okay. Alkalosis is also important because by far common, or by epidemiological, it is far more common to have a urea cycle disorder as well.
Ma'am, please go ahead.
Sirisha, yeah, Sirisha, like just go back, do not come to neuroimaging, go back. So how do you summarize your history? Because see, you from history, you smoothly transitioned into examination. I also thought like I'll let you just present before I interrupt. So how do you summarize your history? Just be here, it's fine. You can summarize your history. So what did you gather from your history?
History wise, ma'am, it's a term baby. with born of non-consanguineous parentage, and there were no antenatal risk factors to mother.
Are you sure there are no antenatal risk factors? You said she is on some medications.
Yes, ma'am. No, not sure, ma'am.
Sorry?
We can't comment on the antenatal risk factors. So,
Okay.
term baby born of non-consanguineous parentage.
Mother diagnosed to have Graves' disease. That is also an important thing to summarize in your history, isn't it?
Yes, ma'am.
Yeah. Okay.
With hyperthyroidism and gestational diabetes in mother.
Okay. What else did you get in your history? Very important history to summarize. Some antenatal diagnosed, we did discuss antenatal ventriculomegaly, isn't it? So always in your exams or even during your presentation, it is important for you to summarize history before you move on to the examination. So antenatal ventriculomegaly, yes. So any other important history which you will go back and ask the mother whenever you find a neonatal seizures, which you have not told us till this point of time. Of course, maternal fever, etc. for touching. Yes. But anything else which is very important? Yes.
During
Pratibha.
delivery. No.
Pratibha has put increased fetal movement.
Fetal movements.
So it is very important for you to elicit that increased fetal movement. She is gravida to abortion 1. She may or may not kind of perceive that kind of increased fetal movement. But if you probe into the history, they might be able to tell that, yes, the baby was kicking a lot, etc. Especially if she is a gravida to live 1, then it is all the more important that you ask her, compared to your previous baby, did you perceive increased fetal movement? So increased fetal movement is something which is very important thing which you have to elicit in your. Also, you said very peculiarly, it's a term baby, but the baby was sent on EBM. What would a normal baby be discharged on?
DB, direct breastfeeding.
Direct breastfeeding. So is it not striking you that you need to summarize in your history that the baby was not established feeding, that
Yes,
has been feeding issues? Okay, that is much more common compared to that is coming as an high alert to me even before you go into baby presented on day 7 with seizure.
Yes, mother
Right.
observed was not proper sucking. Yes, ma'am, that is also significant.
Okay, so in your history, what do you expect in an autosomal recessive condition? So you said there is no family history of inheritable. What do you expect in an autosomal recessive condition?
Any similar complaints in the family?
So do you get that history in an autosomal recessive condition? So how does it happen? Similar history in the family. You get that in your genetic pedigree chart. Generally, you don't get anything in your autosomal recessive because they are only carriers.
Yes, mother and
right?
father. Yes.
They will be mostly carriers. So you will get a very clean history. Even if you put a 3-generation pedigree, hardly ever you get anything in your autosomal recessive condition. Very occasionally, maybe if you are putting like 10 pedigree, 3-generation pedigree chart.
So lost the connection or any odd?
Sir, I'm there.
No, madam is speaking.
Sorry, something happened. Yeah. Okay.
How is that? Okay. All thing in right track now. Probably.
Am I audible?
Yeah, you're audible, ma'am. Please go ahead.
Yeah. So you will not be getting anything in your pedigree as such. Okay, so that is very important for you. So just practice how to summarize history. Okay, very important for your daily routine as well as your exam. So how you are going to summarize very important salient features in your history. Coming to your examination, you said like drowsy, arousable. What was the behavioral state of the baby? Is it important to put across the behavioral state during your examination? So what are the behavioral state you know of?
Stuporous,
Mhm.
but
you aware
arousable to pain stimulus.
Any Brazelton, Prechtel? Are you aware of any behavioral state of the baby? Prechtel staging, Brazelton staging.
Digital staging.
Okay, so in any newborn, if you are talking about acute condition, then you have to put as Volpe staging. If it is a chronic condition, it is always better to, it's not an acutely unwell like inflow, sick and ventilated. You can always tell in the form of Crechtel or Brazelton what behavioral state the baby was during at the time of examination, rather than saying drowsy, arousable, etc.
Okay.
You said like no cataract. So how did you come to the conclusion of no cataract?
No visible thing.
How?
Red
How
reflect.
did you come? Red reflex. So how do you look for red reflex? How do you look for red reflex? Are you there, Dr. Sirisha?
Yes, ma'am. Yes, ma'am.
Yes. How do you look for red reflex? So whenever you're doing a neurological examination, yes, you have to put a Brazelton staging. So red reflex, you should be able to tell the examiner how you have looked for red reflex. Are you using ophthalmoscope routinely in your day-to-day practice?
Yes, ma'am.
Yes. Okay, then you should be able to tell me how you elicited red reflex, isn't it?
In dark room, we just see with ophthalmoscope and look for the reflex.
So do the mother and baby always nursed in dark rooms? Not necessarily, isn't it?
Yes.
It might be darker, but you cannot say that you will be eliciting only in dark room. So what is the distance between the eyes and the ophthalmoscope in your eliciting red reflex, roughly? How close do you go?
1 meter.
No. 1 meter is like too long. As close as possible is also wrong, and 1 meter is also wrong. Like around 40 to 50 centimeters is what you will be looking at. Around 40 centimeters, I can say. Okay. I think in red reflection. Yes.
Ma'am, that's the problem of people working in completely in ICU without going to the postnatal ward to examine a normal newborn. When the normal newborn postnatal ward, every baby goes through the red reflex. If somebody completely works, she has joined 20 days back only, completely ICU posting. Probably previously,
Okay.
any pediatrician, she joined to neonatal fellowship training, but it's a message should be clear to everyone. If I see a normal newborn in the first day, the eye checkup that includes as a normal routine clinical examination. So we should all know if somebody cannot answer hip examination, how to do hip examination, how to do eye examination. It's a big clinical thing is missing. So they all should know. But see, I understand she is not able to answer probably because she joined to 3 weeks before and in ICU completely work. But I'm telling the message when exam wise we are giving message to everybody. Clinically, this which can be done should be done for everybody. If you don't have MRI, it's okay. You don't have high end technique or metabolic test screening is okay. But missing a eye examination, missing a hip examination, it should not be in the clinical bedside examination when we're talking.
Very true. I have to agree with you. Like, I think it's very basic and everyone should be. See, we first want you to do a thorough examination before jumping to, high-end equipment or high-end examination. So again, regarding your growth, which growth chart do you follow? Is it important for you to mention, because you said it is appropriately grown? Is it important for you to say like which growth chart you have used?
Sirisa, you have to unmute yourself. Probably you muted, so we are not able to hear you. Sirisa, you have to unmute.
Fenton?
Sirisa,
Okay, someone has answered.
so you have to unmute actually before answering.
Fenton's growth chart, ma'am.
Fenton's, you do not use intergrowth 21? Any specific reason why you do not use intergrowth 21?
Preterm babies till 40 weeks we use Fenton's growth chart.
No, this baby, what growth charts you used and why? I'm asking only for your baby. I'm not asking about preterm. Okay, read about growth charts, ma. Okay, so and also you need to say whenever you are telling about something, whenever you are mentioning about growth, you need to mention like what growth chart you use and why did you choose that chart. You should be able to answer. And like, what is your inference? You had an antenatal ventriculomegaly and the head circumference is in normal centile. So what is your inference? So your head circumference was normal centile, but you had ventriculomegaly. What does it infer as such?
That which was in the antenatal period might have reduced in size, ma'am. Some of the ventriculomegalies come down.
Okay, you are optimistic. Okay, let us assume that ventriculomegaly is there. What is your inference? Ventriculomegaly with a normal head circumference. What is the likely etiology? You are getting my point. Yes, correct. Aparna has answered. It is cortical atrophy. In the sense, you have reduced brain matter. So that's why the head circumference remains, normal in spite of your ventriculomegaly. Or the ventriculomegaly itself is because of your reduced cortical matter. Okay. And it's a good idea to put the demonstration of the reflexes rather than saying that, okay, reflexes is this one. Maybe in your next presentation, you can include like how you did reflexes, how you elicited Moros, how you elicited plantar and palmar tasks. And again, I think as my colleague mentioned, your line of investigation, your ammonia is missing here. Generally, we remember by baseline investigation for IEM as GALAT, glucose, ammonia, lactate, ABG, and ketones. So all these things should be present whenever we are evaluating the baseline.
It is present.
Okay, but baseline should come, ammonia should come before your MRI, right? Like you were about to present MRI. So what is your first line of medication for seizures?
I mean, this baby levetiracetam was given, ma'am.
Okay, what is your first line of medication? Okay, of course, after taking care of your TABC, temperature, airway, breathing, circulation, phenobarbital is your first line.
Yes, ma'am.
But like you never landed up giving phenobarbital, I understand, right? Like you gave levetiracetam followed by phenytoin, followed by lacosamide. Am I right?
Yes, ma'am.
What is the mechanism of lacosamide and what is the evidence in neonatology? Okay, if you do not know, it's fine, but go and look it up. All the mechanism of phenobarbital, mechanism of phenytoin, mechanism of levetiracetam. If you are using glucosamide, what is the mechanism of glucosamide?
Lacosamide, it acts through sodium channels.
Okay, mechanism of phenytoin.
Phenytoin also sodium channels.
Phenobarbital. Levetiracetam. Okay, so just prepare a chart on all the mechanisms of medications and what chart you need to, what things you have ruled out.
Okay.
So which metabolic condition will be ruled out by your normal CSF glucose? You said the glucose was 86 or something. Like which metabolic disorders will be ruled out by that?
Glycogen storage disorders will be ruled.
CSF glucose being normal, which
Glucose transport defect will be ruled.
okay, good. GLUT, isn't it? GLUT1. Yes, GLUT1 will be ruled out by. Okay, so any specific reason you did the CPK?
And hypotonia was there.
Okay, so what is your interpretation? So what is there in your mind? This hypotonia, did you think it is a central hypotonia or a peripheral hypotonia?
It was mixed, ma'am, in this baby. Both features were present.
No,
No,
what is your
yeah.
diagnosis? Is it a central hypotonia or a peripheral hypotonia? Is it because of nerves, muscles, neuromuscular junction you thought, or is it because of brain you thought?
This is central hypotonia.
Central hypotonia. Okay. Well, what is the role of CPK in central hypotonia? You only showed the investigation that you have done CPK. So why did you do CPK? Can you substantiate that?
To rule out actually peripheral hypotonia in this case.
No,
CPK will rule out peripheral? Okay. I think my colleague wants to speak.
I think, see, when you should be very specific. CPK is a muscle enzyme, right? Muscle enzyme.
Myopathies.
No, not myopathies. Majority of CPK would be raised only if muscle is breaking down. Correct?
Yes, sir.
Yes. So what are the conditions where muscle is breaking down? Myopathies, muscle doesn't break down. Muscle is not functioning normally. Majority of the time CPK is very minimally elevated, maybe 10, 20, 30, 50 values more than the upper limit of normal. But muscle breakdown will happen in process called as dystrophy, correct? The common muscular dystrophy is Duchenne muscular dystrophy. It doesn't present in neonatal age group. But the question here is, what are the... So when we ask for CPK in certain, as an investigation for a seizure, it's not actually to look for hypotonia. Hypotonia is an important clue there, but it is not actually to look for peripheral hypotonia. So the question here is, what are the causes when you suspect the baby is dysmorphic, baby has some structural malformation, baby is peripherally hypotonic. So, and you said that baby has features of central as well as peripheral hypotonia. So how do you differentiate between central and peripheral hypotonia, Shirisha? Yes, I think somebody has rightly answered. Congenital muscular dystrophies or dystroglycanopathy is a commonest congenital muscular dystrophy, along with muscle eye brain disorders and all those things. They can present as central as well as peripheral features. So it involves central, that is brain, and peripheral, that is peripheral nerves and muscles. So there are certain disorders which will involve both central nervous system and peripheral nervous system. Congenital muscular dystrophy is one of them. What other disorders can you think about which can present in neonatal age group with central and peripheral involvement? I think there are very few to name. Congenital muscular dystrophy is one of the commonest which will present with central and peripheral. Mitochondrial may, but primarily presents with central involvement. As the time goes, they may develop peripheral neuropathy. Yeah, I think that's what. So the CPK here in this context should be ordered to look for congenital muscular dystrophies because there are clinical clues to investigate that.
Yes, sir.
Right? It is not actually to look for peripheral myopathy. Peripheral neuromuscular disorders.
Yes, sir.
Okay.
We did not get an answer. Just to Sirisa, to question, because Madam was asking, Nikit also asked, Just we did not get an answer how to differentiate for a bedside clinical discussion time, how to differentiate from central hypotonia to the peripheral hypotonia. I am presenting a case. Before coming with hypotonia, what I am using, then I am differentiating central or peripheral hypotonia. What are the features I will look for so that my differential diagnosis will narrow down. That's Dr. Series. How do you will answer that? You are presenting tomorrow a case, a floppy baby, hypotonic baby, any baby you are presenting. The question comes central or peripheral. How will answer that? How will proceed clinically?
Yeah, and in the similar context, I would also ask, I think, how to what is axial hypotonia and what is appendicular hypotonia as well? And how does it help in differentiating central and peripheral? Or does it really help or it doesn't help?
Sir, in central hypotonia, there will be, baby will be like drowsy with encephalopathy along with hypotonia. In peripheral hypotonia, baby might be alert and muscle weakness will be more in peripheral hypotonias along with hypotonia, and reflexes will be present or exaggerated in central hypotonias. In peripheral hypotonias, deep brain and reflexes will be absent.
Okay, I'll ask you one more question. Down syndrome is a classical example of central hypotonia. Is the baby drowsy?
No.
Okay. So drowsy baby, it is very difficult to differentiate between central and peripheral. It can be anything.
Yes.
I mean, we can still kind of narrow down, but we cannot completely differentiate. But that's, I think that's not the point which will differentiate between central and peripheral. You said that some muscle weakness.
Muscle weakness.
Muscle weakness is important. Reflexes are important.
Yes.
So central hypotonics, in simple words, they are strong hypotonia. So when they are doing active movements, they may have anti-gravity movements. They may appear strong, but when they are not active, they may appear very floppy. Or when you are passively examining the tone might be very low. Versus in a peripheral hypotonia, then even the active tone as well as passive tone, both of them would be low. So there would not be any anti-gravity movement. The baby may have very flickering movements depending on the severity or what disorder we are looking at, or may have only along the gravity movements. So they will appear weak and they will be hypotonic. And central hypotonics are strong and they are hypotonic.
Yes.
Okay. Reflexes in peripheral hypotonia may be diminished or absent completely depending on what disorder you are looking at. Versus central hypotonia, it can be variable. It can be either just present, it can be normal, or it can be exaggerated, again depending on what condition you are looking at. But they would never be absent.
Yes.
Okay.
Madam, again, anything clinically? So there are any particulars we can go for presentation?
Yeah, please go ahead, please.
This is not full view actually. This is in the person who is handling can go for full view. Slideshow mode. It is not in slideshow mode. Sirisa, are you handling or somebody else is handling from a different system?
Sir, IT people are.
IT, Lakshman is handling. So please go for the slideshow. Yeah. Which slide you need, you can tell few of the slide you have to advance.
Given control to Dr. Sirisa, sir, she can able to change the slides.
This is an issue because we spoke that. I don't know. I don't understand what's
Sir,
happening.
I'm not able
the slide
to
is not.
control.
Okay, Sirisha, which slide you want to go? Tell him, he will move to that slide.
Sir, up MRI slides.
Lakshman, please go to that MRI slide. So go back.
Previous.
Go back. Okay, from here you start.
In this baby, neuroimaging MRI brain was done, which was showing. Next slide. Polymicrogyria was observed in both frontal and parietal regions, and subependymal cyst was seen in the ventricles, and some vermis hypoplasia, pontine hypoplasia was also seen in this case. This is the same MRI picture showing polymicrogyria and subependymal cyst, and some ventriculomegaly was also appreciated. Next slide. EEG was done to see the actual site of onset of seizures. It was showing multifocal onset in both the occipital and frontal regions. As you can see, spikes are seen in this EEG recording. Next slide, please. So EEG report was multifocal onset seizure disorder. So till this stage, we have ruled out the metabolic causes like hypoglycemia, hypocalcemia, and hypomagnesemia. And sodium was also normal. Both hypo and hypernatremia was ruled out. Organic acidemias was ruled out because pH was normal and there was no acidosis. Next, we are left with hyperammonemias and peroxisomal disorders. And after giving the pyridoxine also, there were episodes of seizures. So we don't know whether it is pyridoxine dependency or not. And glucose transporter deficiency was also ruled out as the CSF glucose and plasma glucose was in the normal limit. Next slide. So to rule out hyperammonemia, serum ammonia was done, but it was in the normal limits. There was no metabolic acidosis and lactate level was also normal. Newborn screening panel was sent, which was also reported as normal. Next slide. So CSF glycine levels were done, which was normal compared to plasma glycine, and CSF lactate was also done, which was in the normal limit. So we have ruled out all the metabolic disorders till now. Next slide. So as this baby had antenatal scan showing renal changes, ultrasound abdomen was done postnatally, which was showing grade 1 renal parenchymal changes, and complete urine examination was done here, which was normal. So now we are with a baby who has dysmorphic features with hypotonia and neuroimaging showing migration defects with renal involvement. Next slide. So at this stage, we came to conclusion whether we are dealing with peroxisomal disorders. Next. We have done level of very long chain fatty acids and it was positive, showing increased amounts of very long chain fatty acids, that is C26 and C24/22 ratio and C26/22 ratio. So here this report suggests that it was peroxisomal disorder. So in peroxisomal disorders also there are many types. Common seen is Zellweger syndrome, but here with this report we cannot conclude whether it is Zellweger syndrome. So here we are left with the diagnosis that this entire thing which is causing seizures in the baby is peroxisomal disorder. Next. So peroxisomal disorders are also known for involving the eye along with liver and kidney. So ophthalmic evaluation was done in this baby. Retina was reported as normal and hearing assessment was also done, which was normal. So as I said, in peroxisomal disorders, there are two types, which is first one is like peroxisome biogenesis disorder. In that comes the Zellweger syndrome. And the second one is single peroxisome enzyme deficiencies. Next slide. So confirmation, genetic testing was done. It came out as, next slide, please. Bifunctional protein deficiency, which is has similar clinical phenotype as the Zellweger. So it is also called as pseudo-Zellweger syndrome. So our final diagnosis in this case was bifunctional protein deficiency peroxisomal disorder. So in this case, we followed the approach in the systematic way, ruling out all the causes. Finally, we are left with the peroxisomal disorders. One word about the approach to neonatal seizures. Next slide. So nowadays in the recent ILA, it was given us whether any baby presented with seizures or any doubtful clinical event, better to go with EEG recording and confirm it whether it is correlating with the EEG findings electrographically and treat accordingly.
So
Next.
sorry, before I would stop you here. Go back to previous slide, please. So the message should be very clear. It's not just EEG. It should be continuous EEG. Okay.
Conventional EEG is preferable.
Conventional EEG, or but having said that, you have to record the event. That will give you 100% answer. If you go to that slide, I think you have moved once. Next slide. Yeah. Yes, this one. It's a conventional EEG with recorded events, because not always that your interictal record will give you the answers, what you are looking for.
Yes, sir.
Okay.
If conventional EEG is not available, amplitude EEG can be done. Bedside.
The continuous EEG is recommended and desirable. If not, at least a diagnostic for a few minutes or hours. We can do the EEG, which is conventional again. But the amplitude integrated EEG for knowing the seizure diagnosis, or I am not sure that recommendation how much in practice, how much it is going on. Unless specifically to diagnose some of the neonatal encephalopathy, the seizure is a presentation. Maybe amplitude integrated EEG is recommended in when continuous monitoring to therapy and prognostication we do in HI encephalopathy with seizure. But in seizure is a primary disorder, amplitude integrated EEG in routine use of ICU less definitely. But if we want to like any other monitoring, like today we are monitoring inotrope, we are monitoring blood pressure, we're giving oxygen therapy or respiratory therapy, monitoring saturation. We don't have any continuous monitoring majority places for the electrical activity of the brain. We know we have loaded one medicine, phenobarbital, going to a second medicine, going to calcium, going to magnesium. We don't know how the response is happening. So to know that, probably the continuous way of EEG, amplitude integrated EEG might help. But diagnostic technique, are we sure diagnostic any use of?
Yeah, as you correctly said, I think diagnostic wise, if you have to diagnose any paroxysmal disorder to be a seizure or no seizure, I think amplitude integrated EEG has no role. It is a conventional EEG with recorded events will definitely give you. I think it's better that we have a clear observation by an expert or an experienced pediatrician, neonatologist, or neurologist, whosoever is available. That will give you more better answers than amplitude integrated EEG for diagnosis of seizure or no seizure.
So in one of the Hippocrates, we had a chat with Maria Bonifacio. She had come for one of the Hippocrates. He said, like, I do not know what is clinical seizures. They said, like, it's only, like, we diagnose only with EEG. That was long time ago. It was maybe 10 years ago. So we have a long way to go as far as seizure diagnosis is concerned. All of us know our shortcomings in terms of, inability to monitor continuous EEG, which is the gold standard and which can diagnose all the discrepancies can be smoothened by the use of conventional EEG with the video recording, especially with the event recorded. I think that is a way forward. I have few questions for Sirisha in her rest of the presentation.
Yes.
You said like pyridoxine was given, there was no response. So what is your next step in terms of treatable disorders where there is refractory seizures? You give pyridoxine and there is no response. So how do you go about it? Do you take it as, okay, it cannot be treatable, or do you give active form of pyridoxine?
Pyridoxine can be given in any form of refractory seizures. It can
You
be
have given pyridoxine. There is no response. What next in terms of treatable condition?
biotin.
Pyridoxal phosphate. Yes, many have answered pyridoxal phosphate. It is available as Tetra Pol Plus. So it's a tablet form. You can crush and then give it through NG tube when the baby is actively throwing seizures. Along with that, folinic acid is also recommended. Not folic acid, folinic acid.
Folinic acid.
Pyridoxal phosphate and folinic acid. Remember, your CSF glycine can be elevated even in pyridoxine dependent seizures. Whenever we are dealing with metabolic or IEM seizures, your eyes should always focus on what is treatable rather than what is not treatable. If, for example, if you are going to diagnose NKH or non-ketotic hyperglycemia, there is not much treatment option available, except that you could try some medication, but it's not going to be effective as such. So you need to concentrate on what is treatable. So as far as treatable is concerned, glycine level can be elevated both in your pyridoxine dependent seizures as well as PNPO deficiency. So elevated CSF glycine per se is not, important. What you should take is in context or a paired plasma glycine and CSF glycine. So if your plasma glycine itself is normal, there is no point in asking for CSF glycine or calculating the ratio as greater than 0.08. Calculate, NKH. Only if the plasma glycine is very much elevated, 3 times or 4 times normal, then you ask for a CSF glycine and try to see what is the ratio of CSF glycine to plasma glycine. If it is more than 0.08 in neonate or 0.04 in older children, then you take it as NKH. So that is one of your learning points, which I wanted to tell. Then again, you mentioned as newborn screening. Is it a correct terminology to use? The newborn screening, when will you do screen? Or when do develop the country? We do newborn screening extended TMS for all our babies born in SRMC. Newborn screening, a correct terminology to be used for this baby. Sirisha? Okay, yes, it should be TMS. And also remember, whenever they are reporting newborn screening, see whether it is a screening lab which you have sent. Say, for example, when a newborn is being screened, even elevated glycine will not be reported because glycine encephalopathy is something not treatable. Whenever we are doing newborn screening, we are aiming to diagnose something which is treatable. Okay, so the newborn screening labs may or may not report something which is not treatable. So you need to be careful when you are liaising with your lab that it is for diagnostic purpose you are asking TMS, and tell them as to release the report as diagnostic TMS rather than as a screening. You are getting me? You are getting my point? Yes. And also, do you have your plasmalogen levels? I know that you have done your...
We didn't do plasmalogen.
Okay, C22. So up to what T levels or acyl carnitine levels you will pick up in TMS?
Up to 22.
Then you could have picked up in TMS itself, isn't it? Why 20, are you doing 20. It? Okay, up to C18. C18 is what you can pick up with your TMS. Routine TMS will not pick up something which is longer than C18.
Okay.
So, whenever it is more longer than C18, then you have to ask for a specific testing for very long chain fatty acid assay. And also you can ask for plasmalogens level. This phytanic pristanic will be elevated only when they start taking all the other diet. With milk feed alone, it will not be dilated. It will not be elevated. Your phytanic and pristanic and all, it will not be elevated. And remember, your, peroxisomes are the only place where you have alpha oxidation happening. In mitochondria, beta oxidation alone happens. Whereas peroxisomes are the areas where your alpha oxidation also happens, and you have different chains of fatty acids. Okay, rather than only the proper long chain as only even chains. To have odd chain also in dealing of odd chain also happens in peroxisomes. That you need to remember. And go back to your genetic report. Can you interpret the genetic report for me? Are you confident that like you are dealing with only bifunctional protein deficiency? So what is variant of uncertain significance?
You can display the previous slides so that discussion, Dr. Sirisa can discuss.
Yes. You stand here. So what is this uncertain significance?
Previous slides.
Or maybe we can ask her to interpret from the left-hand side of the page and then go to right-hand side and try and understand what she means by this. Yeah.
Yes, please. Because she is only 3 months old. I think Nalnika then they will not be calling me for the next session if I ask her too much. Okay.
Absolutely. It is a learning session, ma'am. It's a learning session. It's every question goes, it is helping them. For the examination, they're learning for examination and for life.
No, I just want to break the ice for Sirisha. She's not opening her mouth. Sirisha, do you want to interpret?
Defect in the gene HSB.
Okay.
At the location point of exons 13 and 17.
Good. And what is the variant?
Variant, I'm not able to.
Okay. So the first line here says as C1084A greater than T, no? So
Yes,
that is what is happening at a nucleotide level. There is a substitution which has happened at a nucleotide level. The next line says that what has happened at a protein level. So P lysine 362 ter is terminating. Generally, remember, whenever it is a terminating mutation or terminating variant, it is either pathogenic or likely pathogenic. It cannot be, like, usually they would not classify as VUS. Because it is terminating and it cannot cause a whole functional protein. So the first line is at a nucleotide level. The second line is at a protein level. So at a protein level, you can either get a missense mutation or a nonsense mutation. At a nucleotide level, we call it as either a indel or substitution. So both the things is a substitution of one nucleotide for the other, or otherwise you can call it as point mutation. And what is happening at the protein level is seen in the next line. And also, if you see here, zygosity, which is likely compound heterozygous. So compound heterozygous is when it is not present in the same exons, but present in different exons. So what you should do as a next step is to ask for parental gene variant testing for both these exons, for both the parents. We have seen cases where, it is clinically fitting into compound heterozygous, but yet only one of the parent was carrying both the variant. Then we had to search for other etiologies. So you cannot take just compound heterozygous as disease causing unless and until, especially when you have a VUS on board, even though there is a clinical correlate, you have to evaluate the parent to establish whether this one gene variant is from one parent and other gene variant is from the other parent. So you have to do these two gene variants. And bifunctional protein deficiency is also one of the peroxisomal disorders where it is, it is not a, if you take Zellweger, peroxisomes itself is not formed. It is more of a biogenesis defect.
Yes.
Its inheritance is autosomal recessive, and classification, it is according to ACNG. You classify into 5, out of which benign and likely benign, they will not report. They will report only VUS, likely pathogenic or pathogenic. Only 3 things they will report, out of which uncertain significance. You cannot take it just for granted that uncertain significance will be significant only. You need to take in context. If you take in context with this baby, I would agree with you that this baby had antenatally detected ventriculomegaly, has dysmorphism in terms of broad forehead. There is a very typical MRI picture in terms of, there is polymicrogyria, with the ependymal cyst, and also renal involvement is also very specific in these peroxisomal disorders. So I would say that there is definitely clinical correlation. For you to establish the genetic correlation also, you need to go ahead with the gene variant testing. What can be done for this baby as such? Generally for Zellweger spectrum disorder, biogenesis defect or peroxisomal biogenesis defect, not much can be done in terms of changing the natural history. They have multi-system involvement. They are progressively, they can worsen. You can give some, assistance in terms of feeding, establishing feeding or putting a peg gastrostomy to feed the baby because their reflexes might be slowly deteriorating. I have seen, many Zellwegers. My latest or biogenesis defect, my last survival will be around 10 months, not more than 10 months. They slowly deteriorate, they lose their reflexes, etc. So, but at least if you have to establish the diagnosis so that you could offer a prenatal in next pregnancy, you need to test gene variant testing for both the parents. And also a good idea to get the plasmalogen levels for the baby to establish the plasmalogen levels to see whether how is the plasmalogen.
Yes.
Okay, just a quick question regarding the same slide. What is below the disease name? There is something written as OMIM and there is a number. What do you mean by that? So it's
Mendelian,
Okay, online.
yes.
Tell Sirisha, you're right.
Mendelian inheritance, sir.
Online Mendelian inheritance.
Inheritance in mammals.
And
Mammals.
mammals. Yeah.
Yeah. And the number is a disease number. Each disease would have a number. Okay. So if you go to actual, if you get the report in your email, you can actually click on that and you will get all the information about that disorder. If it's a printed report, of course you cannot, but usually. Okay.
In fact, hash followed by 1 or 2 will tell you whether it is autosomal dominant or recessive.
Yes.
So the number which is following the hashtag is something which is already established in human. You have different symbols. The one which is not established will not have a hashtag. So if it is a hashtag followed by like one number, previously it used to be like 1 for autosomal dominant, 2 for recessive. Because it is now outnumbering, now they have added like 6 also for autosomal recessive. It goes on like that.
Yes. Okay, I think we can move on probably with
last box. Yeah.
I think somebody is also asking folinic acid. Folinic acid is present in tetrafol plus. So it's a combination of pyridoxal phosphate and folinic acid.
So it is available as leucovorin. If you want a standalone folinic acid,
yes.
It is available as leucovorin. Very well-known medications which used in anti-cancer
Oncology.
along with anti-cancer therapies in oncology.
Okay, before we move on, can we go back to the previous slide about yes, maybe ILA1. The one before this, yes. So if you go to the next column where when EEG is not available, can you read that column?
When EEG is not available, that event should be observed by an experienced personnel.
Yes.
And
then
if the experienced personnel is available, to classify it into focal clonic or focal tonic or other seizure types. If it is clonic or focal tonic, it might be.
What do you mean by that? What do you mean by that? And what is the level of evidence there?
Level 2B is in focal clonic or focal tonic.
So it has got, so it has got high level of evidence as compared to other seizure types. Okay.
Yes.
So what seizures? Now go to that ILA slide.
Next slide.
Yeah, next slide.
Next.
Yeah. Okay. So what are the type of seizures which are mentioned here in electroclinical?
Any baby with clinical suspicion, go ahead with video EEG or amplitude integrated EEG. If there is EEG correlate.
Yeah. So
If
no,
it is
I just want you to read the type of seizures.
in electroclinical, sir.
Yes.
Motor and non-motor.
Mm-hmm.
In motor, it can present with automatisms, clonic, epileptic
Mhm.
spasms, myoclonic, and tonic.
Mm-hmm. And
In
non-motor.
In non-motor, it may be autonomic, behavioral arrest,
Then sequential and unclassified.
yes, sir.
Okay. So 4 major groups. So with what do you mean by sequential seizure?
It starts at one point and
Sorry.
the onset of seizure will be at one point.
Hmm. So clinically, what will be the correlate? You might have heard about motor march, right?
Yes,
Yeah, it's kind of similar. So one event leading to another event leading to third event. So it's a continuation, but the manifestation during that continuation might be varied. It may not be a different type of seizure, similar type of seizure moving from one part to other. Yes, I think it's not exactly focal followed by generalization. It's very similar to motor march. Okay. Now, out of these seizures, which seizures, just by looking at seizure, you can definitely say that this is a seizure. You don't need investigation to prove or disprove it.
clonic and myoclonic seizures.
Clonic and myoclonic. What about sleep myoclonus? It's a myoclonus. Is it a seizure?
No, sir.
No. So, clonic, yes, I agree. Then, the clonic can be focal clonic or generalized clonic. Either of the things, they are seizure. What else can be a seizure? Just by looking at the event.
Tonic seizures also can be seen clinically.
Tonic, is it focal tonic, which is definitely a seizure, or a generalized tonic, which is seizure? It's a focal tonic, which is definitely a seizure. Epileptic spasm is definitely a seizure. So apart from this, you may not always be able to tell that event is seizure or no seizure. You have to take help of EEG in that situation.
Yes.
Okay. So clonic, focal clonic, generalized clonic, focal tonic, and epileptic spasms.
Yes, sir.
Okay. Yeah. Can go ahead probably.
Next slide, please. In the management of seizures, if any neonate present with seizure, it is important to confirm it with EEG. As I said, if it is not available, it should be confirmed with an experienced person. After that, the first line of anti-seizure medication will be phenobarbital. And only in special consideration, if there is any family history of channelopathy, phenytoin, fosphenytoin, carbamazepine. In second line of anti-seizure medication, we can go with phenytoin or fosphenytoin and levetiracetam, followed by midazolam and lidocaine. In second line anti-seizure medication also, if that is confirmed by EEG that it is vitamin B6 dependent epilepsy, then we can go ahead with pyridoxine. So this was another management of neonatal seizure, which was given in IAP guidelines. Next slide. So paroxysmal disorder, ma'am has already discussed about this.
So we don't think there's a detailing of this particular disease required. You can go through the FA management, any issues, how the baby status or the thing case you can describe. We don't think paroxysmal disorder as such we have to present here.
Okay, sir. Next slide. So in investigation part, we look for one is a very long chain fatty acids and plasma lotions. So there will be decreased beta oxidation. So there will be accumulation of very long chain fatty acids, and plasma lotion synthesis will not be happening. So there will be low plasma lotions in paroxysmal disorders. Next slide. Next slide. So in paroxysmal disorders, there will be association of many systems. One is vision will be disturbed due to retinal involvement, and hearing also affected. Liver will be involved in many cases of paroxysmal disorder. So in this case, LFT was normal. And predominant will be encephalopathy with refractory seizures and hypotonia. Next. There were very few case reports on bifunctional protein deficiency. The clinical picture will be very similar to Zellweger, but compared to Zellweger, it is somewhat milder form of paroxysmal disorder. Next slide. Next slide. So in this current case, baby is currently on oral phenobarbital and levetiracetam. Some feeding difficulties were there in swallowing, and sucking reflex was poor. At present, there is no signs of any liver dysfunction. No renal issues were also documented. Opthal and hearing assessment is also normal. Occupational therapy is going on for this baby and on regular follow-up. Currently, seizures are in control, and there were not many episodes in a day. And baby is gaining weight. Next. Thank you for giving me this opportunity.
So you can stop sharing the PPT, and madam or all the faculties can ask few of the questions. Then we will try to take, if some relevant questions is not answered and they were asked by the delegates, we can go for that. So, including Dr. Vamsi, Madam Umameshwar Madam, and Dr. Nikit, you can ask few of the questions if you feel unanswered during the presentation.
So I think well done, Sirisha. Like you have done a comprehensive, that too at your early stage of your fellowship, you could comprehensively present. So that's well done. So it has to be more systematic, and neurological examination has to be a little bit more elaborate in terms of even assessment of tone. How did you assess active tone? How did you assess passive tone? Like maybe because it is a short presentation, you have to include all the investigations and management issues. Whether you cut down on it, I'm not too sure. But generally, whenever there is a tone abnormality, you might have to elaborate on the neurological examination a little bit. So I suppose you would know like how to assess active tone and passive tone. Sirisha?
Yes, ma'am.
Okay. So active tone assessment is by what maneuver do you do for active tone assessment? It's 180-degree flip, right? Active tone assessment is by your 180-degree flip, and passive tone assessment is doing some maneuvers and measuring the angles.
Yes.
All your angle measurements will be for passive tone assessment, and your 180-degree flip will be your active tone assessment. It is important that whether only active tone is affected or passive tone is also affected, and whether you observed any time during your evaluation, how was the movement, whether the baby demonstrated any movement against the gravity or not. Those things also you need to bring it out in your examination as. Otherwise, like comprehensive presentation, we'll try to answer some of the questions which are asked from the by the delegates.
One question again we discussed, but it came differential, how to differentiate between axial and appendicular hypotonia. That one clinical question there.
Sirisha, do you want to answer? How do you assess axial? You said both axial as well as appendicular is reduced. How did you come to that conclusion?
If there is axial hypotonia, if we do the suspension, trying to hold the baby, there will be slippage of the baby through our.
So that is axial or appendicular?
Axial.
Okay, then appendicular?
Ventral suspension.
The axial is by like your flexor tone and extensor tone of the neck. Okay, and then like in your maneuvers, how how the back is curved. It's appendicular tone is basically what axial is your central, like your back and spine is your axial. Appendicular is your hands and legs. Okay, so that is how whichever maneuver you are doing to see whether the spinal, the neck flexors, extensors, those things are your axial. Okay, appendicular is when you are doing your all your maneuvers, what is your angles, those things is very high. Those things will indicate both mode of appendicular.
Yes.
Okay. So that is how you will differentiate. So someone has asked the trade name for pyridoxal phosphate. One of the tablet which is available is Tetrafold Plus. Tetrafold Plus. So that is a combination, but it has pyridoxal phosphate also. We have used in one of our babies with refractory seizures with pyridoxine dependent seizures. Initially was looking like not responding to pyridoxine, so we put on active form also. Even some of the pyridoxine deficiency itself, sometimes they might respond to active form. Later on, you can withdraw. For that baby, we did all ASA, alpha aminoadipic acid, alpha aminoadipic semialdehyde, and pipicolic acid. So those were also elevated in CSF, plasma, and urine. So whenever my take home would be, whenever you are approaching IEM, you have to have like which is treatable, that should come to your mind. So my approach for refractory metabolic seizures will be do a GALAC. If GALAC is normal, or all your organic acidemias, amino acidopathies, and FAODs, fatty acid oxidation defects are ruled out. Then you see what is the response for pyridoxine. Elicit history for increased fetal movement. Then if baby is responding to pyridoxine or not, then you give active form of pyridoxine followed by folinic acid. See for look for response. Then start evaluating for, CSF amino acids and CSF glucose. CSF glucose will rule out GLUT. Whenever it is, in GLUT, it will be very less than 1/3 of the CSF glucose to plasma glucose will be very less, consistently less without any infectious etiology. So that you can diagnose GLUT. Serine levels are less in CSF, that is serine synthesis defect. That is also one of the treatable cause of neonatal seizures. Then you look for glycine levels. Then you do a urine sulfite dipstick and urine sulfocysteine. That will help you to differentiate with sulfate oxidase and molybdenum cofactor. So that will be my approach for metabolic disorders. But however, keep in mind that always look for treatable, and treatable. So molybdenum cofactor or sulfate oxidase will have lens dislocation only later on. It will not present in the newborn period. So don't go by the book description that you have to find a lens dislocation at the presentation of seizures. Usually it happens, it evolves over a time. But what you find consistently in MRI is cystic encephalomalacia. A baby who is not having HIE at all, but presenting with cystic encephalomalacia, then you need to put your antennas should go up in terms of molybdenum cofactor deficiency or sulfate oxidase. You can do a uric acid. It's available in all the labs to differentiate these two. So that will be my approach for metabolic seizures.
Yeah, I think there is another important cause of neonatal seizures which we did not discuss at all. They would usually present as neonatal tonic seizures with plus minus apneas. Along with that is a primary startle syndrome. I think very easy to diagnose bedside just by tapping your nose. Your baby will jump. It's also called hypereclepsia. It's a glycine related this. I mean, it's not a hyperglycemia, but it's a glycine receptor. So they're very easy to diagnose primarily because of the seizure type and the bedside clue. And the only thing which they would respond is this thing. I mean, clonazepam.
Hypereclepsia. Those we are
Yes.
that we consider as a differential diagnosis for neonatal seizures. Like our seizure mimics as such. We did have like one baby with hypereclepsia. Really like easy to do as a bedside, but very poor prognosis overall. That baby did not do well.
Yeah, it depends on what is the genetic. I mean, some genes would. I mean, there are 4 genes associated. Some babies do very well. Some are actually associated with seizures, and they are very typical generalized tonic seizures to an extent that baby will go into apnea. Yeah. So any such seizure, I think it is important that you pick up hypereclepsia as a clue. Or a startle as a clue, and then treat it accordingly. Some of them might do well. Some of them definitely have a poor outcome. Yeah, and then again, another important point which I would like to stress is focal seizures are very important to be picked up. There is another thing which you need to observe if there is a focal seizure is focal paucity of movements, because it may be very subtle. Baby still might be able to move. If it's a hemispheric stroke, baby still might have some movement. It may not be a dense hemiplegia as what we would have seen otherwise. So it's an important clinical examination to prove or disprove and to limit the number of investigations. And of course, it has treatment implications as well.
Madam,
Folinic acid trade name is leucovorin. I think some have asked. How does pyridoxine phosphate working different from pyridoxine? See, basically, pyridoxine deficiency is not in the pyridoxine pathway at all. To have your vitamin pathway, this pyridoxine deficiency, which we classically describe as pyridoxine responsive seizures, is not in the pyridoxine pathway at all. It is in the lysine pathway. It is one of the amino acidopathies which is happening in the lysine pathway. What happens is there is one substance called as P6C, which goes and inactivates the pyridoxal pathway metabolism. So one other lysine pathway, from there it is going and tripping into the interfering with the vitamin pathway metabolism. So that is why when you give high dose of pyridoxal, which is very supraphysiological, 10 to 15 milligram per kg as an ongoing, then that is enough to overcome the problem with that P6C causing interference with the pyridoxal pathway. Whereas PNPO deficiency, otherwise we call it as active form of pyridoxal, where you will give only pyridoxal phosphate, that is in the pyridoxine pathway itself. So that you need to remember. No need to mug up the pathway and all, but you need to know these differences. PNPO is in the vitamin pathway, whereas pyridoxine dependent seizures is in a different pathway, that is in the lysine pathway or amino acid pathway. That's why it differs in its action. Hope I have answered the Roshin's question here. Sir, you were trying to say something. Nalinikant sir, you were trying to say something.
I'm telling actually, please, you have written the article. The students are asking, instead of Galact, they are pronouncing it Galact. So somebody's asked the question, did not get the message. So I just put a image of Galact with how increase, decrease. But please, ma'am, explain actually how what are the Galact 5 principle and how to go ahead. Because they probably may not know, they may not have gone through your articles in IJP, the review article, which I am aware,
Okay.
but the student.
Sure. Do you want me to share the screen?
Yeah, you can say, ma'am, not issue. As a faculty link, you can say that.
1 second, just 2 minutes. I'll just open my slide and then. Is my screen visible?
Yeah, visible, but the now you are saying that's visible.
Okay, so GALAC is for like glucose, ABG, lactate, ammonia, ketones. So depending on what is happening, we might be able to, baseline differentiate between organic acidemias, fatty acid oxidation defects, etc. When glucose is non-contributory, when the ABG is showing acidosis with the mild lactic acidosis or lactates being normal with elevated ammonia and elevated ketones. What is this? You can put in your Q&A or chat box. All of them might be tired. Okay.
Yes, I can fact fatty acid oxidation. That's the answer coming.
Okay. So remember, in your urea cycle disorder, you will not be getting a ketone positive, and also acidosis will not be much. Okay, so the hyperammonia will stimulate the brain center and it will cause respiratory alkalosis. But remember, that is only in the initial presentation. In a dying baby, if you are doing, all lactates will be elevated, all acidosis will be there. So don't do a baby who is dying in shock and tell that this baby is having primary lactic acidosis. That is not the way to diagnose as such. Okay, so this is like organic acidemia. This is a very typical picture of organic acidemia. Okay, acidosis with ammonia elevated and ketones being positive. This one, ammonia elevated with respiratory alkalosis. So just now we discussed, right? What did we do? Yes, urea cycle disorder. Okay, so again, this is the initial presentation. Whenever the ammonia is very much elevated with respiratory alkalosis. This one, hypoglycemia, ABG is showing normal or acidosis, lactate is elevated, ammonia is elevated or normal, ketones are reduced, or hypoketotic hypoglycemia. I'm getting NKH. See, remember, all your type 2 neurotoxicity disorders, whatever we described right now, pyridoxine dependent seizures, non-ketotic hyperglycemia, molybdenum cofactor, sulfate oxidase deficiency, GLUT, everything will have normal GALAC. GALAC will not be abnormal in your non-ketotic hyperglycemia. Okay, so they are called as type 2 neurotoxicity syndrome, where you will not have abnormality with GALAC at all. Okay, so this one is fatty acid oxidation defect. So ketones are low and hypoglycemia is there, is fatty acid oxidation. So here this is a condition where glucose is normal or reduced, ABG is normal or acidosis, lactate is very much elevated, ammonia can be normal or elevated, ketones are like neutral, non-contributory. So this is your primary lactic acidosis. Okay, so your pyruvate dehydrogenase or pyruvate carboxylase deficiency. So how do you differentiate? Pyruvate carboxylase will have hyperammonemia and hypercitrullinemia. When you are doing a TMS, you will get citrulline elevated. Whereas pyruvate dehydrogenase deficiency typically happens in boys. They'll have dysmorphic faces. What is this condition? Where GALA is normal, glucose, ABG, lactate, ammonia is normal, ketones alone is elevated. Dr. Arjun has answered.
We're happy that
It is
getting right answer.
MSUD,
Right
maple,
answer.
maple syrup urine disease. So because the ketones will be both. And remember, GALAC being normal, it's all your neurotoxicity type 2, pyridoxine dependent NKH, all will have normal ketones. Normal GALAC. Normal GALAC, normal TMS, normal GCMS, those will be non-contribute.
So then, thank you, ma'am, for this clarification and this algorithm. At least the students are aware that they have to approach with some basic investigations before reaching to the TMS or GCMS or before reaching to the genetics.
true.
At least by using the common investigations, how to get the clues with the clinical correlation, and then later they can go for, because this algorithm may not give us all the answers to all
Correct.
the disease we have.
Very true.
After so many investigations, after doing TMS, after doing extended TMS, GCMS, we are clueless many a times, and many disease comes later. So, but the basic approach, 80% of IMs probably we can go to the provisional diagnosis with this GALAC approach. The people, students understand today this message, probably the job done for IM, how to evaluate. So, one question I will take towards neurology. Dr. Nikita, I will ask the questions came. So, I want to do an MRI for an IM baby or a neurology baby. What timing, how will choose? What time will be appropriate to do MRI? That's the question comes actually from the student. Just I want to highlight.
I think it was asked a couple of times during the discussion. I mean, as far as I understand, I don't think so there is any specific time. I mean, when we talk about MRI, timing of MRI, it's more about HI, because HI changes, they would normalize after 7 to 10 days. And if you do an MRI, there might be a false normalization. But in terms of seizure diagnosis, if you are looking at any metabolic disorder or any biosynthesis disorder, or any other primary genetic, neurogenetic disorder or structural disorder as a cause of neonatal seizure, I don't think so there is any ideal time for MRI, to making the diagnosis. I mean, whenever we suspect, if in our sequence, if there is an MRI coming up, I think we should just do it. I mean, it's not about that if we do early or if we do late, we'll miss out the diagnosis.
Like, can I add something to it?
Yeah.
Basically, I think maybe compared to neurologists, neonatologists, for us, like it is easy to interpret diffusion restriction in nature, because it is easier. It comes across to us very strikingly. As you are getting more experienced, I think you will get used to T1, T2 images also. So whenever you want to catch up something which is very early on, and you want to catch up in your diffusion restriction itself, then time the MRI like within around within 5 to 7 days of your primary, when whatever happens. Say, for example, you have a HAE, you want to time it early enough to catch up the diffusion restriction changes itself, you time accordingly. If you want to go for your T1, T2 changes, which is more permanent and which can predict the long-term neurodevelopmental outcome, you're not worried about the etiological perspective, but you want to prognosticate and you want to go for your long-term outcome, then you time in such a way that you get to see your T1, T2 changes. So basically, our protocol, our neonatal seizure protocol, we always do MRI along with MRS. I'm insisting more to do MRI with the MRS is because sometimes your metabolic report will come very late, but you can get a clue in your MRS. It can be a branch chain amino acid at 0.9. or it can be a galactose, which is there at 3.5 ppm, or it can be, elevated glycine, which is present in the MRS. So you could get even, like glutamine peak can be picked up sometimes in hyperammonemia when urea cycle disorder. So to get those clues, you ask for MRI with MRS. Especially if you are going to practice both newborn as well as pediatrics. Creatine deficiency is, even in the recent OutCon, we presented 4 children with developmental disorder and autism who have a diagnosis of creatine deficiency. Out of which, like 2 of them, they missed an MRI because they did only MRI without
only
MRS.
MRI.
So
Yes.
the MRS will give us a lot of clues. Even lowering of creatine can be detected in the children presenting with seizures. So I would think that whenever you are considering MRI, include MRI with MRS. And you might be asking for a contrast if you are thinking an infectious etiology as a strong, you want to rule out meningitis, or ventricular meningitis is there in your clinical picture, you want to see whether there is ventriculitis, then you have to go for a contrast imaging. Otherwise, there is no need for contrast imaging. Just ask for plain MRI with MRS. Time in such a way that, like, after your whatever insult has happened, if you are doing early enough, you will be able to pick up your diffusion restriction changes. If you are timing it little later, you will be able to pick up your T1, T2 changes.
Yeah.
Timing when comes for a clinician like me, it priority comes if there is already antenatal suspicion diagnosis or a congenital anomaly or a developmental anomaly. Probably timing is no issue. As per your stability, respiratory stability, cardiovascular stability, you do every convenience. But a disease which is an evolution, natural course, acquired disease, then probably timing in those cases like HI or a stroke or a thrombosis, those are the cases when you have to time it to do the best image. And for the intervention, if you feel the MRI can help for intervention, then do whatever sequence extra, but do it early so the intervention can save time and disability. So these are the typical principles. How to get the which sequence, which imaging, which protocol to follow, unit-wise, and the unit protocol-wise little different. Some of the neuropediatric neurologists, they are very fixed on some of the protocol and the image sections. But our purpose as a clinician, we should know, okay, this disease diagnosis can help us in intervention and some recovery. Do it early. If the disease is already diagnosed antenatally, the disease already established, that any point of time will be give us similar type of imaging, not issue. But like typical examples, what I was speaking here, HI cases, there is an evolution of disease over 3 days or 4 days. We want to catch one imaging, like Western protocol, twice imaging, somebody can do with MRI center. Maybe the decision will be different. In India, what do we do? Once imaging, it should give us the best the prognostication and the diagnosis. Those cases probably we have to wait for the timing where we can best use our MRI imaging. But neonates, if stable, clinically stable, cardiorespiratory stable, probably if we want to diagnose, earlier the better to diagnose. So no point in waiting for longer in an established disease pattern. That's the common message I want to say. And any other questions? Probably not much questions. So we are 10 o'clock also today. It's a very engaging and interesting discussion happened after the of respiratory discussion, ICU, ventilation, ABG, X-ray. Now we went into a different area today where we discussed clinical examination, bedside clinical clues, which will give us the diagnosis, supplemented by all the questions of Dr. Mameswari madam, and Dr. Nikit also well supplemented here with his inputs. And we learned today how to approach with basic investigation, how to reach to help for a diagnosis, not going to the high-end investigations. So these are the few things we have to keep in mind. If one message I will include in Dr. Bamsi, one message, because it's 10 o'clock, I don't know to extend longer, but one message from each. Dr. Sirisa has done a good job because she also got a short time because the case when present ready, she prepared that and already the case was already diagnosed and she came shortly to the unit and she prepared an extensive PPT and presented to us. And we lots of input she must have learned also today. And with that, I will say one message from all the faculties, then we can go for the closing session. starting from Dr. Vamsi. He has not spoken anything. Dr. Vamsi Krishna, you can put a whatever message to the student and the audience. Then we will, two of the faculties will request, and then you can go for closing session. Dr. Vamsi, are you there? So we are not getting him. So Madam, Uma Maheshwari Madam or Nikit, one message to the student. Already you started with a message at the beginning of session. I'll still say some of the learning tips for the student.
I think I would say systematic approach and look for treatable causes always.
Yeah, I think I would also agree with that. It's the same thing. I mean, you should have a systematic approach. You should have a thought process. You shouldn't approach a symptom as just a symptom. I mean, it's a lot of things should be going around in your mind at the same time, and then you should be able to narrow down on what is there, what is not there, what should be done, and what should not be done. There are many tests available, but you should be able to narrow down to very few tests to get the answers in a very economic way.
So from my side, one message I will give here. So before giving the message, I thank you both the faculties for excellent inputs and so much learning for me also, and all the moderator and the students for presentation, and the participants. So till late, more than 100 of participants till now, they are present now. So before closing, I will say, if you're in examination, don't miss the clinical findings and examine symptoms and signs are the key for the initial to build your diagnosis later. And when you are examining, try to learn, you need to throughout the process. For each disease, there will be some of the typical key handles. If our learning process, we will use those handles, and other clinical parameters around that handle we use and try to search. Probably we will get many rare diseases before the final genetics or imaging talks about the finding. By the clinical examination, comprehensively, if we will approach with the keys, with the handle keys of the different disease, we can probably reach to the diagnosis. That's many times we used it. We reach to different diagnosis. So the handles, when I'm meaning clinical handles, the laboratory key like Malak handle, imaging MRI, you are asking which MRI specific signs we will look for. And the easy we are doing easy also sometimes typically give us the diagnostic clues. Like that, use those handles. It will give a specific narrow down differential diagnosis to proceed further. With that message, probably thanking all of the faculties, I will close the session today, and we'll see again next week, Thursday, with a neurology case again. But which case we don't know, because we are requesting everybody, if all audience and delegates are listening, if you are a very specific case you got in your center, please put a message and present that. Otherwise, we will request, as per the sequence in the neurology section, whatever the cases we'll try to present here. Thank you all. Thank you, Uma Maheshwari Madam, especially to you, shortly participating, extensively discussing and guiding the students, and Dr. Nikit. With this, I will close the session today. Bye-bye. Good night.
Yeah. Thank you. Good night.
Thank you.